health records and information officers. So they were oriented on how to key in data on day-to-day basis. And this tracker is updated on a weekly basis. So every Friday of the week, the data officers and the HRIOs in our facilities, both at facility the regional level, updates this tracker. Among the items being keyed into the tracker, equally health management and information use needs, and also issues to do with healthy commodities. So at the end of the day, we had weekly reports from 56 KPS facilities being reviewed to assess the implementation and the success of the tracker. To take us home, this is a pictorial representation of the tracker, and the tracker has been coded in terms of majorly 4 colors. 4 indicators, which will be indicating as red, meant that we were seriously underperforming in that area. So for indicators in yellow, we were fairly well. For indicators that will be represented in gray, we were doing good, while those in green, we were meeting our targets optimally. So just to take us back, the facility and the regional data officers were all given access rights in terms of access rights to key in, while the managers at the station level and also at the regional level and national level were offered few only rights. So as you can see, from the 15 or so indicators, the first indicator is HIV testing. So it monitors the target, first achievement, and also the proportion therein. For instance, for HIV testing, as at 25th of June, when we submitted this presentation, we were at 75%. For HIV testing, or rather positive identification, we were at 92%. The only indicators that we were not doing so well is TB start. That is the number of TB clients who were started on treatment. They were 72%. And those, and the TXCAR, that is the number of clients in our care and treatment, they were 67%. And the last indicator which we were not also doing so well is cancer screening among women of our reproductive age within the HIV care services at 59%. So the tracker gives us or auto-populates the current performance for the facilities, regions, as per indicator, and also by quarter and month. It also monitors facility specific in the type of key performances. This is where data entry is being conducted. It also monitors issues to do with condom promotion, because we appreciate that condoms plays a key role in terms of HIV prevention. But someone may ask, why are you offering condoms to our inmates? Yes, we are offering condoms to our inmates at exit. So it is part of the exit strategy. Equally, issues to do with RTKs and consumables are being monitored. So this is the overall performances. As you can see, this is just about a visualization of the overall performance, and also region-wise. You could see Nairobi in our dashboard is the first region, followed by Nyanza, Western, and so forth. So As a manager at that facility in the region and even at headquarters, you can clearly see which of the indicators we are not performing so well. This is the interface for data entry, and I just pointed out for the Western, where you could see Busia is one of our prisons, and Shikusa, just to mention but a few. And the indicators, just like the ones I presented before in the overall performance, are the same we are monitoring, and also the months across the columns and rows. For commodities one of our key LD component, because without commodities, actually performance achievement cannot be realized. So from these performances, in terms of commodities, the tracker can be able to actually predict what we have as we start as a beginning balances. Number two, what did we receive from KEMSA? That KEMSA is the Kenya Medical Supplies Agency. And did we have any positive or negative adjustments? How many number of tests did we have during the month or even the week? And lastly, of the test kits that we add, the ones we use in terms of testing, what is the closing balances? So what are we learning from this tracker? Number one is that as Kenya Prison Service, it has enabled our work in terms of program achievements to be realized. So monitoring of our achievements within the Kenya Prison Service facilities has been made promptly. And the great issue, the correctness, the reliability of data that we have is now being realized. And whenever we have underperforming indicators, we have corrective measures. What are some of these corrective measures? Number one, we offer what we call continuous quality improvement for those underperforming indicators. Number two, we also do data reviews. And lastly, support supervision and technical assistance to those facilities which have underperforming indicators. We have had also issues to do with commodities forecasting. From the commodities tracker, you could clearly know what are the stocks at hand, so that should there be a need for either positive or negative adjustments, you can do it promptly. Another component is the HMIS, Health Management and Information Use. As a country, we are going towards digitization, and even from this conference, what has come clearly is that we need to digitize our health services. So as a country, we are going towards digitization, and we have noted that whenever our data officers indicates in the tracker that there are any HMIS needs, we partner with our development partners to provide the same. So we have seen identification of HMIS needs being identified and fixed promptly. As a country, we are also embracing technology in terms of point of care. Currently, 54 of our facilities, of our care, HIV care and treatment facilities, offer point of care in terms of HIV services. So we are using the digital electronic medical record, and in some of the facilities we are doing both paper and electronic fashion. From the management of our prisons, they have also noted that accountability of our staff is now has now come to a realization, because as a manager, you would wish to know what is the performance of your staff within the health facility. So from the tracker, as it is updated on a weekly basis, you could clearly see and track their performances. Issues to do with accuracy and consistency has also come out very clearly, that with a tracker, we can monitor from all the reporting channels, and this has been achieved. So as at March 2024, as a service, we have had 8,820 of our clients being enrolled to care and treatment, compared to 7,891 in the previous year. In terms of HIV testing, our testing was 51,908 during that reporting period, compared to 24,368 in the previous year. In terms of TB screening at entry, we have seen TB screening rise to 42,811 from 34,450 the previous year. So overall, we have noted that there is improved real-time data-driven decision-making within the Kenya Prison Service, and this is a work in progress as we continue to improve the tracker to also cover some of the indicators which we could not be monitoring at the moment. In conclusion, the use of simple but cost-effective and high-yielding data demand and information use tools is very key. So it is our respected view that if this is embraced, it increases, number one, efficiency, improve real-time data-driven decision-making in our elder facilities. And therefore, ladies and gentlemen, it is our recommendation to this conference and our brothers and sisters in detention facilities that we could adopt this tool. May I acknowledge the management and prison service, our clients, that is the prisoners, prison staff and their families, and also members of the community for having faith in our services. And we could not do all this without partnership from the ministry in charge of correctional services, the State Department for Correctional Services, the Ministry of Health, through NASCO and National Syndemic Disease Control Council, LVCD Health, and also county governments. County governments is specifically mentioned because in Kenya, health is a default function. I thank you.
Thank you very much, Mr. Ezekiel. And I think your recommendation is really heard. And if you recommend, that means you are also ready to share your practice, your experience with others who want to adopt this tool. So thank you very much. And now, ladies and gentlemen, I want to invite Mr. Ernest Kimutai Chebo. He is an inspector of Kenya Prison Service stationed at the headquarters. He is registered clinical officer, specialized pediatrics and child health. He is currently TB HIV National Clinical Coordinator. So Mr. Ernest has 15 years experience working in prison health with 5 years as health facility in charge. So additionally, he has National Advanced HIV Clinical Course, University from Nairobi. So leadership in global health, project management and monitoring and evaluation, all from the University of Washington. So he has also various master degrees, training of trainers in HIV treatment areas. He is also a member of TB HIV working group, I think, TWG. Okay, it's a working group. He also participated in Global Fund and grant writing proposal for Kenya Prison Service. He is also passionate to realize future prisons free from infectious disease. Thank you very much, and let's welcome Mr. Ernest Kimutai.
Thank you, sir. Sorry for that. All protocol observed, ladies and gentlemen, allow me to take us through this presentation from the Kenya Prison Service, building on the foundation that was laid by my brother, and I would not want to repeat part of the issues that he was able to put the building blocks for this, my presentation. I come from, offside the presentation, I come from Rift Valley, where there's a lot of mountains. And in this, my home, it's surrounded by mountains. And some of these mountains, they have monkeys. And some of the monkeys there. So when a child is born at home, my mother told us that he had gone to the mountain to collect a baby monkey. And we all believe this narrative until even standard 6, that this is true, that children come from the mountain and from the monkeys. But then recently, my kindergarten daughter cannot believe such narratives. Because the technology, they know what exactly happens. So you cannot sell those narratives to them anymore. Technology has made it possible that while you are conceptualizing something, somebody has already picked that idea through AI, through a lot of mechanisms in terms of technology. For instance, today, the president of Kenya will be engaging young people through X, yeah? And he will be engaging them because of the technology. So basically what we are saying is then that we're leveraging technology. And of course, we are just using the WhatsApp mechanism to be able to achieve what my brother Ezekiel was able to explain in the tracker. So basically, allow me to take us through memory lane, that again, technology and telemedicine, mobile phones, internet, and wireless broadbands technology are become more advanced. The use of AI, for instance, what my brother in Benin was presenting around use of TB, use of AI to diagnose tuberculosis. Well, that is exactly what's going on. That is the next frontier. And so again, it requires us to use technology to approach medicine, to use technology even in our screening mechanism in prisons, to use technology to be able to help us. Otherwise, analog approach may not be able to solve most of the issues. And so again, patient communication and consultation through medical images like the X-rays, scans, real-time audio, video education, and all these become reality now. Yeah? I can sit and probably a colleague in Coast region could send me a picture of a particular skin condition, and you could request that we would want to be supported, what this could be. And we could be able to share within our forum, and immediately there are a lot of information that is coming. So basically, telemedicine also decreases the travel expenses and also the expenses in medical use. It lowers the medical costs, saves time, and it has made it easy for common person consultations. And so again, we have the WhatsApp, we have the Well Show, we have other mechanisms. But basically, this is just a very simple component of WhatsApp. We are talking about the HIV. Let me take you through the memory lane of the HIV situation, globally and Kenya. We have 40 million people HIV infected, and 1.6 million in Kenya. 30 million globally and on ART, 1.4 million in Kenya. New infections, 1.3 million, 45,000 annually in Kenya. 0.6, I mean, slightly 650 HIV-related deaths, 18,000 in Kenya. People people in prisons, about 500,000 people in prison. And in Kenya, who are HIV infected. But in Kenya, we have about 4,000. 25% then of the overall people in the global people HIV infected are in Africa, 25%. But in East and Central Africa, 16%. West and Central Africa, 6.5% in people in detention. Sorry. We are talking about ART. We are using this to achieve the goals of HIV management. What is the goal of ART, for instance? The goal of HIV, that is antiretroviral therapy. We are using the WhatsApp mechanism to the calls of ART. And some of this is the maximum. So if at all there is any program on HIV programming that do not achieve maximum viral suppression of less than 200 copies, it's not a successful program. And so we wanted to put a program which we ensure then that we achieve viral suppression of less than 200 copies in every individual. That is one. Number two, to ensure then that there is what we call a restoration of immunity. Yeah? So that our clients will restore immunity through what we are calling CD4, differentiated cell number 4. Screening for opportunistic infections and related cancers. So that again, we are talking about cancer screening and the use of TPT, TB preventive therapy. We are also ensuring that we retain people in care. For instance, if the 4,000 that we have on care today, the 4,000 that we have on care, we are able to retain them on care so that they exit prison alive, they live life long, to be able to explain to other people the benefits they got in prison. And so again, retention in care. 20 years from now, they should be alive and they should be productive. The other thing is reduction in new HIV infections. Something we are calling U is equals to U. U is undetectable is equals to untransmittable. So this is what we need to achieve through an HIV programming. So achieving this means we have to use a program. Last month, there was a struggle to climb Mount Everest. And one of our brothers climbed there called Cheruiyot. And unfortunately, he passed on in the middle of somewhere while he was going to the mountain, the summit. And we were unable to retrieve his body, and he was left there as a legacy in Mount Everest. Yeah? So in the process, there was the starting of we are starting from a baseline that we need to reach the summit. And reaching the summit requires a lot of efforts. It requires a lot of concerted efforts from prisons, from partners, and more importantly, the technology. And in this regard, we needed to ensure then that our elder care providers are mentored and trained to be able to deliver. We ensure then that we wanted to accelerate their service uptake. What my brother presented today is the targets. But again, the bearing is upon the clinicians to deliver. To ensure then that we achieve our outcomes and to have a motivated elder care providers who are able to be motivated in terms of if you achieve your targets, then you feel motivated. We are also having the success in HIV programming and also a sustainable program that is able to be sustained, and the gains that we are able to achieve, we maintain it over time. And in this regard, we are talking about Nairobi County. Nairobi County, in terms of not the Nairobi region, we have mapped our prisons into regions. So Nairobi region has 10 prisons. The 10 prisons in this Nairobi region, 10 facilities. And in these 10 facilities, in March 2023, they had 2,204 clients on care. These 2,404 clients on care, we narrowed down to 5 indicators which were performing poorly. Yeah? And one of the indicators then you've seen is cervical cancers, CD4 uptake, for 10%. Viral load uptake, 82%. Suppression, 79%. TPT, 48%. and cancer screening 5% as at March 2023 for 2,204 clients. An average of all this gives us 44.8%. And the performance ratio is we should achieve 95% across most of these indicators, specifically viral suppression, viral load uptake, TPT, and all that. So basically, we are to engage the clinicians. And so we began from Nairobi. We started a WhatsApp group for the clinicians. And the clinicians were able to share every week on Friday their performance. From today, this afternoon, after this presentation, I will be able to be reviewing performance of the 10 sites in Nairobi. And now, immediately they share their performance across the target indicators. What happens is then that we are using what we are calling short, sharp, that's called the prioritized short, sharp, service-specific indicators. So what is this? We prioritized 5 indicators. We prioritized the indicators that is having a poor performance. And these indicators we derive from the electronic medical recording. What my brother has just presented earlier, we pick the indicators that are non-performing. And we expect the clinicians who are 100 clinicians in the WhatsApp group. So on Friday, they share. And immediately they share the facility level program that shares on weekly performance. The mentors, we have about 5 mentors who will review this particular data on spot. And when you review through a short message, then what we will do is then that the mentor triangulates, the mentor triangulates with previous performance and other data sources. Structures are what's called the bullet eye. What do I mean in bullet eye? For instance, if you say you identified 1 HIV positive this month, this week, what we'll expect of us is, has this person been screened for TB? And has this particular client been over TBT? That's 1. Has the client received CD4? And for instance, if you say they have received CD4, the lab report, you are able to check back in and be able to realize that this particular client has not received the CD4 count. And we are able now to report on that. So we are able to triangulate and we are able to give that particular facility an immediate mentorship to be able to address that particular need. The issue of service. 1, we are prioritizing a service at a particular time. So what we are saying is that 1 prioritized service at a time is discussed, focused on the benefits of AFTEC and how it affects the facility performance. And so again, we were so specific, we contextualize to suit individual client needs and facility performance. So every Fridays, when they share the facility report, every facility will be able to receive a short message enumerating the issues that they need to address per their report and their performance for that particular week. And after implementing this for the last 1 year, as at March 2024, which we are here, our target was 95%. Our CD4 rose from where it was 10% to 74%. And the 74% is because also of issues of cartridges, which was missing, and it was a national issue. But viral load uptake rose to 94%. Viral load suppression to 99%. And also TB uptake was 99%. And the other aspect is cervical cancer screening is 82%. For instance, today, if a facility reports that they have done 5 clients, cervical cancer screening for 5 clients, we are able to look at the data, which my brother presented earlier. And we are able to showcase to them that you already have 50 clients that you're able to miss this particular week. And next week, you will be having about 20 clients who are coming to your clinic. Kindly address these 20 clients for cervical cancer screening. And basically now we are able to monitor and we are able now to encourage the clinicians together. And so we were able to achieve 89.4% overall from 44%. What are we saying again? the approach which we were using, what we are calling the short, sharp approach, is that we realized the remarkable results that sparked an average rise in service uptake from 44 to 89. Within, of course, there was a mistake here, within 1 year. The same approach can be scaled up in active management of other related chronic conditions. In conclusion, that was my conclusion, and allow us to thank all the participants here and the people who supported us to achieve this. And thank you very much.
Thank you very much, Mr. Ernest Kamutai. And I think really from this session, we really learned that, the world is moving and there are so many opportunities brought by technologies. And, and when I was listening, it came in my mind, maybe, we have also some countries with improved prison system management tools, like Namibia, Ethiopia, which got a new prison management, case management tool. And maybe, I was asking how this tool can be connected to inform health system without violence, health ethics. So, this kind of reflection can be also maybe for the next conference. So let's take a moment and again, thank you, all of you, Mr. Sylvain, Mr. Amdani, Mr. Kimutai, for your presentation, for your rich presentations. We still have maybe 10 minutes, 15 minutes for question and answers. So those who are willing to ask questions, please tell your name and also tell us whom is your question addressed to. Yes. In the middle, I have two names. Okay.
Bien, merci. Thank you very much, John Kunda Barugu. I am head of section the prison service in Mali. So I want to ask my question to my colleague from Benin. I followed with a lot of interest your presentation, and we understood how the prison administration is organized in Benin, that is confined to an agency that is has a directorate and a subdirectorate, and you're confined to a directorate. So I'm talking about the clinics that are in the prisons. At which level are they situated in your country? I have a worry because what do you do? Do you have all the necessary competencies and knowledge to be able to do evaluation and monitoring in these services, comparing them to the external hospitals? Do you not have any limits or obstacles? Do you think that these people who are detained are not detained? And this collaboration with the ministry, is it at what level do you find it?
Can you give it to your neighbor? Then we move on. Yeah, we have 4 hands on that side and 1 here.
Bien, merci.
Thank you. My name is Karim Barou, and I am in the general direction from the Ministry of Health and Hygiene in Burkina Faso. I want to congratulate the presenters for the clarity and concise manner they've done these presentations. I think it was very clear. So mine will be to Dr. Sylvain. I noted that you have a directorate in the prison administration. You have for health and also nutrition and also transport. So my question will be on the collaboration between transport of the patients towards hospitals. Have you even imagined an adapted ambulance that takes into account the security and also to prevent the escape of these detainees, do you have an ambulance that has been custom made to be able to transport these detainees to hospitals? So, or have you reflected on how to do it? So they cannot be classical ambulances. They need to be custom made that take into account the security of both the detained persons and also of the health agents or the authorities that are going to accompany them. I think that is important to think about, and it was asked to hospitals to reserve also secured wards to be able to take care of these detained persons. But we never talk about transport. I don't know if you have that, or you can share with us if you have such ambulances, so that we can be also inspired. When it comes to partnerships, I am a bit. We are stakeholders, and we also government actors. So we cannot just be a partner. We are actors, and the detainees are civilians who have been incarcerated. So when you talk about their health, you're talking about public health. So we need to take into account and conceptualize this and accept that this is the case. We don't say enough, because within health we have our role and we need to occupy our place. We have many other factors, but this conference is really welcome, and I think within the General Directorate, I confess that we need to do a lot within the Ministry of Health to talk about health within the prison systems. Thank you very much. Thank you very much. My name is Kaja. I am from the Ministry of Health in Ivory Coast. I don't have a specific question. I would just like to say thank you to all the initiatives that have been shared. Where I would like to put my attention is actually the developed application on Excel, on Microsoft Excel. Is it what are these applications that have been developed, and is it OBI, is it a query, how is it done? I think that it costs less, and I think it's also to develop them at the strategic level for operational follow-up. Just share a bit how you went about to do it and how you got there to get this data. Thank you very much.
For an insightful presentation. Name is Sanya. I represent Cure.ai. First question is, how can technology partners collaborate with the stakeholders and actors in the detention ecosystem? Do you have suggestions for us, particularly the responsible use of technology and some guidelines for how technology can be useful? The second is a request for ICRC. It would be great if there's a compendium or a repository which can be created, particularly highlighting everybody's experiences of different technologies, what worked, what did not work, and if there are any learnings for adoption or other governments and stakeholders to learn from those who have implemented. That would be really, really useful for this ecosystem. This is a suggestion. Thank you so much.
I think this can be taken as a recommendation, and thank you very much. The neighbor, and we come to you after. Voilà.
Thank you, Dr. Kona. I am responsible for the management of health services in Bokke prison. I have a question concerning the presentation from Benin. I think it was Sylvain who did it. It's true that for a very long time we don't talk about it enough, but I want to know, in his presentation he said that there are some partners that who come to help them on budget matters to manage the detainees. I would like to know, how do you come up with health laws after the offering of the service because it is a very big challenge. We have all these problems to really get the health records from for our detainees. So I don't know how you get the health records. That is just the question I wanted to ask.
Two last questions for the lady. Then
Thank you very much. My name is Martha Ilonga. My question goes to Mr. Ezekiel. It's regarding the online tracker. I wanted to find out that the online tracker isn't only utilized within the prison services, or is it also being extended or connected to the public health system? Thank you.
thank you very much. And the last finger I saw was on my, yeah.
Thank you very much. Amadin is the name. Amadin Olotu is the name. We are University. What stuff I wanted to talk. First of all, let me say thank you very much to the presenters. Things I want to say have already been touched upon, so just mention them quickly. About the experiences have been great. You know, great experiences from all different presenters before now, and I guess maybe even after now. But I just would like, you know, if it were possible to get, you know, proceedings of this that we could somehow access even after now, you know, that would really be great, you know, to be able to benefit from the experiences beyond this place. So if there are proceedings of this conference that are made available to us, that would be great. That's one. Second thing is, I guess some people have already mentioned on the tracker, you know, using Excel. I was just wondering what version. Was it, you know, an online one? Was it an offline one? And I was wondering how much it cost, who paid for it, you know. I mean, cheap, but those things, I really want to understand how you got all of that. Yes, thank you very much. That's all.
Yeah, thank you very much. So we will give the floor to the panelists, and maybe, did you note all the questions addressed to you? So 3 minutes chrono, everyone to address your questions. Dr. Sylvain.
Thank you to the participants for their questions. Let me first start by answering the question from Dr. Conrad. He was asking about how we get health information after they have been treated. So we are forced to cover the costs for treatment and all the elements. So if a detainee person is referred to a hospital outside the prison, the center is going to serve us the receipt and also the services that were offered, and it is us to pay for those services. When it comes to NGOs that I was talking about in my presentation, this NGO is going to take care of all the services that were given. So it's the NGO that is going to pay even the doctors and also pay for the medicine that are given at the pharmacy. And APB does not pay anything there. I hope I have responded to that question. And then when it comes to the question asked by Dr. Ego, he wanted to know what is the level of the hospitals or the clinics that within the prison systems. Yes, sir. So this these agents, first of all, the officers are recruited by the APB, and there are some who depend on the Ministry of Public Services that are not directly linked to the prison service in Benin. But since 2020, all the personnel are now, they depend now totally on the agency. It means that this prison service has its own autonomous budget that takes care of these officers. Now, if we have trainings that are linked to the program, Ministry of Health is going to send invitations to these officers that are working in these clinics, nurses, doctors, etc., to be able to participate in these trainings so that they can also have a level, the same level with other people, other doctors and nurses in the public health system. So the question from Rodrigo in Burkina Faso, he wanted to know about the health feeding program and also transport. When it comes to transport, how do we transport them from the prison to the hospitals? It's a good question. Yes, we have within our establishments, we have standards that respect the international and our prison has an ambulance that is given by partners, but other prisons do not have. So everything we have to do, when you have to transfer to a hospital, there is health officer, an authority that are going to be responsible for the transport of this detained person. So the authority will take care of security and the health officer will take care of the health of this detained person. When it comes to the partnership between Ministry of Health, yes, in one part, true, when we talk about partnerships, because when we want to take care of the health of this detained is at 100%. When we are taking them to the hospital, when he goes to the hospital, we are going to receive the invoices and receipts, and we are going to be able to pay for them. So when we spoke about partnership, because yes, the detained persons are also members of the population, and if we do not collaborate with the Ministry of Health, we are going to have notions that these detained people are not going to benefit from the services that other populations are going to receive. We are not trained for that. That's why we said in my presentation that it's a partnership. So it's actually we are working together with the Ministry of Health to be able to provide health services to these detained people. So thank you very much.
Vous pourrez continuer à échanger parce que sur cette question,
you can continue exchanging later during the breaks.
Yes, and also questions. I wish to answer the delegate from Ivory Coast. That
yeah, it's okay. It works.
Am I audible?
Yeah, it's okay.
Okay. So there were questions from delegation from Ivory Coast. Number one, I wish to confirm that the tracker is cost-free. We developed it using MS Office Excel. And the application, the MS Office Excel has functions and formulas where we link sheets containing the indicators. And for our facilities across the country, we are using Google Doc. So they are accessing the same using Google Docs, where we link their email to the tracker. so that they would be updating. And we also allocate them with access rights in terms of edit rights for those facility data officers and also the health records and information officers. And for the managers, we allocate them few on the rights. So the Excel also has visualization functions for purposes of graphs and charts. So as we had demonstrated earlier. Two other questions in terms of, do we utilize the tracker in other health services? Currently, we are only utilizing the tracker in the HIV and AIDS components of our health service delivery. However, plans are underway for it to be incorporated in the larger key health services. The last question was if there are any payments in terms of the tracker. No, answered. This is, we are utilizing the knowledge on how to operate MS Office Excel. Thank you.
Thank you very much.
Maybe to add on what my brother said, is that we've been able to put all the facilities on electronic medical recording, and all the facilities access internet. All the facilities do paperless. So everything they are doing is paperless, and ultimately then at the end of the week, then they consolidate their report with the data officers, and they're able to load that particular report on Friday. Even while we are seated here, the reports are being loaded now. And so you are able to check and to able to respond. Do not wait at the end of the month to respond to errors. You address the issues head on every week, so that at the end of the month we have all won together. Thank you.
Yeah, thank you very much. I think it's quite time for, and I think there is information for you, especially now we're moving to the closing of these historical events. So, and those who still have questions, don't hesitate to sit with our speakers during lunch and continue your discussions. Okay, the floor remains open until the next conference.
Okay, thank you, Dieudonné Nga. And another round of applause for the moderator and the panel. That's for you. Now we are moving towards lunch, but as Dieudonné said, we are also moving towards the closure, and we need to work together to put down the conclusions and recommendations coming from this conference. That is what will guide us when we go back home to give us the roadmap to try and implement what we deliberated here. So I expect in the next 1 or so minute, Nuria to come here. They are busy compiling. If you still have your recommendation with you, please, this is the time to quickly pass it on. The team compiling are just standing out there with the laptop. If you really still have it and you feel it should be captured, pass it on to that team. I